Hi, I am Dr. Selvaraj, your surgical educator from Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing the surgical clerkship rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. Today in this episode, I am going to discuss one more trauma patient, that is abdominal trauma, the renal injury. I am going to talk in this episode. So the learning objective or the learning outcome is the following points. At the end of, watching this video, all of you should be able to understand the epidemiology, the mechanism of injury, the grading and classification, initial evaluation, management, treatment algorithm, and complications in renal injury. That is my the learning outcome or the purpose of this video. So coming to the epidemiology, among all abdominal trauma patients, 10% of them will get urinary tract injuries. Renal trauma overall, among all traumas, it constitutes 1 to 5%. 90% of the renal injuries are because of blunt injury, the mechanism. Another 10% are because of penetrating injuries. In renal injuries due to blunt trauma, other associated injuries like the injuries to liver, spleen or bowel is 44%. In renal injuries due to stab wounds or gunshot wounds, the other associated intra-abdominal injuries are 40 to 70% in case of stab wounds, and it is 77 to 100% in case of gunshot wounds. Coming to the mechanism of injury, there are mainly three mechanisms. One is blunt trauma, the another one is penetrating trauma, or the renal injury can also occur because of sudden deceleration. That also can cause injury to the kidney. Coming to the blunt trauma, the most common is the motor vehicle collision, or it may be because of fall or direct blows to the flank because of the assault. All these things lead to renal injuries as the kidney is thrust against the rib cage or the vertebral column. The fractured ribs and the fractured transverse process of the lumbar spine can also lacerate the kidney. This is the mechanism by which the blunt trauma can cause renal injury. Penetrating trauma, stab wounds, and mainly it is two types, stab wounds or gunshot wounds, tend to be less predictable and it is more severe compared to the blunt trauma. Stab wounds to the anterior abdomen are more likely to injure vital renal structures such as pelvis, hilum, and pedicle. The flank wounds posterior to the anterior axillary line more likely to injure the periphery of the kidney and non-vital renal structures such as the parenchyma. Gunshot wounds may cause extensive tissue disruption due to the blast effect. Sudden deceleration may stretch the renal artery and produce an intimal tear, producing turbulence, thrombosis, and even occlusion with complete or segmental renal ischemia. This can, or sometimes it can even avulse the pelviureteric junction, PUJ or UPJ. Uretropelvic junction can be avulsed by this. Deceleration means Okay, the sudden stoppage of the vehicle, but body is still moving, and that will cause sudden deceleration, will cause this uretero-pelvic junction disruption. Coming to the grading of renal injury, this is by AAST, that is American Association of Surgery for Trauma grading. So this constitutes of 5 grades. The grade 1 is just contusion, and there may be subcapsular hematoma, but there is no parenchymal laceration. This is what you are seeing in this picture. You are seeing just a contusion, maybe there is a subcapsular hematoma, but there is no parenchymal laceration. Whereas grade 2, there is laceration, but this is less than 1 centimeter depth of the renal cortex. No urinary extravasation, and there is subcapsular hematoma here. You can see it. And grade 3, laceration is more than 1 centimeter of the renal cortex, no urinary extravasation, no involvement of the collecting system here. This is grade 3 is more than 1 centimeter, but it is not involving the collecting system. And grade 4, laceration is extending through the renal cortex, medulla, and into the collecting system. This is the grade 4. You can see it is extending into the calyces here, collecting system, and you are seeing this is the perirenal hematoma you are seeing here. And minor renal artery or vein injury is also grade 4 with contained hematoma. Okay, this is grade 4. Grade 5 is shattered kidney. You can see multiple lacerations here. Kidney is shattered. Devascularized kidney, maybe the hilar injury and hilar avulsion, and there may be the artery may be completely severe, and it will go for ischemia, the kidney. This is grade 5 injury. So there are 5 grades. All this grading we can do only after doing a CECT. This is not a clinical grading. You must do a CECT, and then only we will be able to make this grading. Coming to the initial evaluation of the patient, the goal of this evaluation is prompt recognition and appropriate radiographic evaluation of all upper urinary tract injuries. Yeah, the major blunt renal injury usually occurs with other major injuries of the head, chest, and abdomen. In the history, you have to concentrate on what is the mechanism of injury. Is it a blunt injury, penetrating injury, or deceleration injury? This you have to find out. Then, what is the type of the weapon used for this, to making this injury? That also you have to ask. Then you have to ask the patient whether there is any history of hypotension immediately after the injury in the field itself. This also you have to ask. Coming to the physical examination, you have to ask for the patient whether the patient is having any flank pain, or you are seeing any ecchymosis in the flank. And look for lower rib or vertebral body fractures. Look for upper abdominal mass or tenderness in the upper abdomen. Look for evidence of crepitance over the lower rib cage or the lumbar area. Site of gunshot wound entrance or the stab wound penetration you have to examine. And you have to look for any abdominal distension or ileus. This is usually associated with retroperitoneal urinary extravasation. So then you must do some lab test also, especially the urine analysis. If gross hematuria or microscopic hematuria, that is defined as more than 5 red blood cells per high power field. is associated with hypotension, that is, systolic blood pressure is less than 90, that indicates the need for genitourinary tract imaging. The degree of hematuria does not correlate with the severity of the renal injury. Hematocrit is helpful in selective operative versus the non-operative management of renal trauma. If the hematocrit is falling, then probably the patient is having ongoing bleeding, and we have to explore the patient. If the hematocrit is not falling, it is static, then we can manage this patient conservatively or non-operatively. Creatinine also is very important. If elevated, that suggests pre-existing renal disease, which may change the approach to the radiographic evaluation and the operative approach. So creatinine, serum creatinine is also very important. Coming to the radiological evaluation of renal injury, what are the indications for genitourinary imaging? If we are having a penetrating injury associated with any degree of hematuria, or if the wound tract indicates possible genitourinary involvement, that is an indication. Blunt trauma, this is for penetrating injury. For blunt trauma, if it is associated with gross hematuria or microscopic hematuria associated with hypotension, that is BP is less than 90 systolic, injuries in the proximity of urogenital structures like lower spine, rib fracture, transverse process fractures or pelvic fractures, all these are indication for radiological evaluation of the kidney. Significant history of significant deceleration injury like fall from a height. All pediatric patients with any degree of hematuria, radiological evaluation should be done. The gold standard investigation to evaluate the renal injury is contrast enhanced CT scan. In grade 1, you will see focal areas of decreased contrast enhancement in the cortical area of the right kidney. You are seeing here these arrows. Yeah, the dye is not taken up here. These are not laceration, but because of the contusion, okay, these areas is not taking up the dye properly. So this is grade 1. Grade 1 means there is no laceration, but it is just a contusion with subcapsular hematoma. Here in grade 1, it also includes non-expanding subcapsular hematoma without parenchymal laceration. Okay, this is an ultrasound. The same thing here you are seeing. There is no laceration, but you are seeing a subcapsular hematoma here. Or sometimes there may be an infarct in the kidney. Yeah, this is a male patient, 47-year-old blunt abdominal trauma, subsegmental infarction in the CT. You can see it as a wedge-shaped area of decreased attenuation in the interpolar region of the right kidney. This is the area. See, this is the wedge-shaped segmental infarction. This you can see. This is also stage or grade 1. Coming to grade 2, okay, grade 2, usually there is laceration, but this laceration is less than 1 centimeter size. Small cortical laceration, CT is showing laceration in the interpolar region, arrow you can see of the right kidney, with a small perinephric hematoma. See, this is the thing, and this is the perinephric hematoma you are seeing here. This is grade 2. In grade 3, injuries include renal laceration greater than 1 centimeter, but without the collecting system involvement. So here you are seeing injury or laceration in the cortex of the kidney, but it is not involving the collecting system. And there is perinephric hematoma is there here. This is also a perinephry hematoma, grade 3 only, renal laceration throughout the cortex, extending to the medulla without involvement of the collecting system. Large subcapsular hematoma, a complete laceration of the right kidney, you can see, but you are seeing a big subcapsular hematoma here. Yeah, here you are able to see. This is also grade 3. Coming to grade 4 injuries that include deep parenchymal laceration extending through the renal cortex and medulla into the collecting system. So here collecting system is also involved. Injuries involving the main renal artery and vein with contained hemorrhage, that is also stage 4. So here in this CT scan, CECT, it's a boy, 12-year-old boy. He fell from a staircase, deep parenchymal laceration involving the collecting system. You can see it in the A and B. Involving the collecting system also. A and B unenhanced and post-contrast CT. This is unenhanced means before giving contrast. This is after giving contrast. This picture B. It is showing large subcapsular hematoma. See, this is the this is the kidney involved, and you can see a large subcapsular hematoma here, and here also. Here also you are seeing large subcapsular hematoma, intrarenal hematoma, and corticomedullary laceration of the right kidney with hyperdense presentation of blood in unenhanced scan. In unenhanced scan, you can see the blood is hyperdensive here, hyperdense. Whereas in contrast enhanced, you are you are seeing a hypodense in post-contrast scan. This is hypodense. This is hyperdense area. Blood looks like this. Yeah. And you can see it, these arrows. This is the blood. And here, this is the blood. Yeah. And CT filling defect with, if you see this is a urinary bladder, you are seeing filling defect within the urinary bladder because of blood clot. And this is C. And D, urography they are doing, and you can see filling defect in the right renal pelvis. Due to right renal pelvis, there is a filling defect here because of the blood clot. So you can see not only the kidney, you can do all these things. You can even visualize the urinary bladder. You can evaluate the whole genitourinary tract. Coming to grade 5 injuries, these are most severe and include lacerations that completely shatter the kidney, PUJ avulsion, complete laceration or avulsion or thrombosis of the main renal artery or vein that devascularize the kidney, hilar injury. So here you are seeing two pictures. A male 43-year-old blunt abdominal trauma, avulsion of the pelviureteric junction. PUJ junction is avulsed in picture A. CT you are seeing extravasated contrast medium is extravasated because of PUJ avulsion. And B you are seeing this picture CT excretory phase, extravasated urine with the contrast medium you are seeing here. So extravasation of the dye, that means extravasation of urine also can take place. Okay, this is another investigation, angiogram, especially if you suspect any injury to the renal artery or renal vein, you can go for angiogram. Here in this picture, you are seeing a blunt trauma with left renal artery thrombosis. So this is renal artery thrombosis you are seeing here. B picture is the angiography or arteriography that confirms the injury. Here you are seeing the left renal artery is blocked here. So the artery was successfully restored with an angiographically placed stent. You can see the stent here. Here you can see the stent in the left renal artery here. That is what here it is occluded. Here they have put a stent there, the left renal artery. Okay, this you can do, or in case of false aneurysm in the right kidney, you are seeing in the angiogram, you are seeing a false aneurysm. This can be treated with successful therapeutic embolization or angioembolization can be done. Coil, you can inject the coil through the vein. Okay, it will go spring coil and that will occlude the bleeding site. So this is the importance of doing arteriogram. Coming to the management of renal injury, minor renal injuries that comprise grade 1 and 2 accounts for 70% of all injuries, and usually they do not require any surgical intervention. The major renal injuries like grades 3 and 4 accounts for 10 to 15% of all the injuries. Their management depends on the clinical status of the patient and other associated injuries. Patients who are hemodynamically stable with grade 3 or 4 renal injury may be managed conservatively if ciliotomy is not indicated, that is laparotomy is not indicated for treatment of associated injuries, then you can manage it conservatively. When ciliotomy is indicated for treatment of associated injuries, renal exploration and reconstruction are recommended. Grade 4 injuries involving the main renal artery require exploration. All penetrating injuries to the kidney also should be explored. Coming to grade 5 injuries, this accounts for 10 to 15% of all injuries. The grade 5 injuries involving the renal pedicle always required immediate surgery to control life-threatening bleeding and typically eventually result in nephrectomy. Renal artery thrombosis 6 hours after injury warrants a conservative approach as renal salvage is unlikely after ischemia of more than 6 hours. Unless it involves a solitary kidney, bilateral kidneys, or a pediatric patient, you have to do only nephrectomy. Conservative management of multiple parenchymal fractures may be done in selected patients who are hemodynamically stable at presentation and do not have renal pedicle injury. Urological complication in cases managed non-operatively may often approached by minimally invasive endourological techniques such as retrograde stenting for persistent urinoma. Absolute indications for renal exploration are number 1, persistent life-threatening bleeding, which is expanding pulsatile or uncontained retroperitoneal hematoma, then you have to explore. Or if there is renal pedicle avulsion, then only that is an indication for renal exploration. The relative indication for renal exploration are if patient is having persistent renal bleeding defined as requiring transfusion of more than 3 units of packed RBC cell in 24 hours, then we should explore. If patient is having extracapsular urinary extravasation, if patient is having non-viable renal tissue, or if patient is incomplete staging was done. That means when a renal injury has not been accurately staged preoperatively, an intraoperative one-shot intravenous pyelogram IVP should be performed to pick up any problem in the kidneys, both especially in the opposite or contralateral kidney. You should find out. That is the purpose of doing this single shot IVP. Non-operative approach consists of supportive care with bed rest, serial hematocrit assessment, volume repletion, antibiotics, and careful monitoring and imaging follow-up using repeated CT scan. Operative approach to the kidney, we had to approach the kidney through midline transabdominal incision, not the loin incision. The major visceral and vascular injuries should be repaired first, unless renal hemorrhage is massive and life-threatening. Early isolation of the renal vessels should be done. Incision of the retroperitoneum over the aorta medial to inferior mesenteric vein, and then superior dissection will reveal the left renal vein crossing the aorta anteriorly. Both renal arteries should be easily seen at this time. All vessels are encircled with vessel loops. The kidney is low approached by incising, the kidney is now approached by incising the retroperitoneum lateral to the colon. For massive bleeding, the ipsilateral renal artery may be occluded, but warm ischemia time should be limited to less than 30 minutes. Coming to the complication, early complication, that is within 30 days, are bleeding, infection, perinephric abscess, sepsis, urinary fistula, hypertension, urinary extravasation, and urinoma. Delayed complication, that is beyond 30 days, that include again bleeding, hydronephrosis, calculus formation, chronic pyelonephritis, hypertension, arteriovenous fistula, hydronephrosis, and pseudoaneurysm. Coming to the treatment algorithm of renal injury, renal trauma, you have to look whether your patient is stable or unstable. If patient is unstable, so you have to take the patient to OR and you have to operate. If patient is stable, then only you have to do the CECT. If it is grade 1, 2 or 3, we can observe the patient. But if the patients are having symptoms of any one of these symptoms, pain, fever or hypertension, then you have to repeat the CT scan, or at least you have to repeat the ultrasound, and you have to follow the patient. If the patient is a grade 4 injury with pedicle injury, if pedicle injury is there, you have to do an arteriogram and you can do what is called the therapeutic embolization, or you can put a stent. If there is no pedicle injury, then you can give the patient bed rest, CT scan or ultrasound in 48 to 72 hours. And if urinoma is there, then this urinoma can be percutaneously drained. If there are no urinoma, then you can just observe the patient. If patient becomes unstable, or if the patient is grade 5, grade 5 injury, then we have to explore, we have to do operative surgery only. So in summary, if it is grade 1 to 3, do conservative management or non-operative treatment. If it is grade 4 and vascular injury, you have to do an angiography. Okay, you have to treat it with arteriogram, and according to the finding in the arteriogram, you have to do the surgery or not. If it is involving the collecting system, then we must consider stenting the patients. If it is grade 5, here also you can do, if it is involving any artery or vein, then you can do angiography or you can do surgery. If it is a severe injury, grade 5, then you have to do nephrectomy. So thank you very much for watching this video. If you think that these videos are very useful, kindly subscribe to this channel and share these videos in your social media. Kindly click the bell button also to get notified regarding my latest uploads. Thank you once again for watching this video. Let us meet in yet another episode. Until then, bye bye.